Hello, welcome to JAMANetwork Open Live. I'm Seth Kruger, Digital Media Editor at JAMANetwork Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, send us your questions or comments at JAMANetwork Open on Twitter, or you can send us, you can enter into the comment box under the video in YouTube Live or Facebook Live. Today, we've got a couple guests. We're talking about the Association of U.S. Households Disaster Preparedness with Socioeconomic Characteristics, Composition, and Region. And we've got both authors, Dr. Lucila Zamboni and Dr. Erica Martin. Welcome.
Thank you for having us.
Thank you.
Yeah, really glad you could both join us. So first, just give us a little introduction of who you are and what you did here in the paper, why you thought it was, what was the driving force for doing the study?
Well, I'm Lucila Zamboni. I have a PhD in public administration and policy with a concentration in public health. And very early in my professional career, I had the opportunity to work and, I guess, experience firsthand large-scale epidemics and what they meant for more vulnerable populations. So after that, drove my interest in public health emergency preparedness with a focus on equity and vulnerability. And I guess that was like what kind of pushed me through my doctoral work and looking at different kinds of I guess, disparities in the context of emergency preparedness and how to think about them. So this manuscript and this work is part of that thought process.
Great. Hi, thank you for having us. I'm Erica Martin. I'm an associate professor of public administration and policy at University of Albany at Rockefeller College. I'm a public health services researcher, so I've been thrilled to be able to work with Dr. Zamboni on this paper. And I think this really highlights the important role that public health plays in terms of helping that populations are healthy and prepared. And this is particularly relevant in today's era of dealing with the pandemic.
Okay. Great. So tell us what you did here in the paper. It looks like the main thing was using the American Housing Survey section on preparedness.
Yeah, so using the American Housing Survey, the topical section on emergency preparedness, we selected a subset of the sample that responded to 9 items on emergency preparedness. And what we did was to classify this, taking like a novel approach, classify these 9 items into what we are calling resource versus action-based preparedness. And we look at how different socioeconomic characteristics at the household level would predict or have an association with these different types of preparedness and preparedness overall. And we found some very interesting things.
Yeah, so some of the findings were actually quite counterintuitive. So, for example, we might expect that households of higher socioeconomic status, so those with higher incomes, those with higher education, you might expect them to have higher preparedness in all of these dimensions, and that's not what we found. So not surprisingly, these households tend to be more prepared on these resource-based items, but they also tend to be less prepared on some of these action-based items, such as having an alternative meeting plan. Some findings, we might expect that female-headed households, that they are less prepared on resource-based items that might have to do with what they have in the household. But then we have households with children in the family happen to be more prepared on having an alternative meeting point. So that might actually come from work that parents are doing with the schools in order to have these plans. And so, we find that there's a lot of differences and variation, that there's a lot of opportunities for increased preparedness across the board, but in particular, it's not a conventional and straightforward story that some groups are just simply less prepared.
Yeah, I found it interesting, the split between the resource and the action-based plans, preparedness plans. So the resource things, I think, the kind of first things I would think of, things like food stockpiles, financial resources for evacuation. Those are kind of intuitive. But as you said, things like having an evacuation meeting point or alternative communication plan, those action-based things. Those, you don't just have that sitting around your house. It's not something you like buy once and stick in your, the back of a closet somewhere. And I don't know, I found that really interesting. And then, Also just with everything, the current situation with COVID, it's always interesting to me in disaster times, and I don't have a lot of expertise or any expertise in disaster preparedness specifically. It's always interesting just how specific each type of disaster is, and how things like evacuating isn't going to be helpful now. Like, say, if there was a tornado or a hurricane. Can you speak to that at all?
Yeah, and I think that's a really good point, and I think that was part of the driving force behind splitting these preparedness items into action and resource base. I think that prior research on emergency preparedness stays kind of like halfway, and although they identify which elements households need to have in order to be better prepared, they kind of cut short in terms of what's the nature of each one of this item in looking at what's the actual emergency that we're facing. As the current situation is showing right now, the nature of the next disaster is very, very, very hard to predict. However, if we only prepare in one single way, meaning we only stockpile, we only have an emergency backpack that we can use to evacuate our home if we need to evacuate, it is just not enough. In this connected world in which we're all working outside the household, the present situation is definitely an exception. Not being able to communicate with your family or your loved ones in terms of where to go next if you cannot return home is something that sometimes we don't think about. But definitely when you start bringing in these nuances of preparedness, you get a better picture. I think that at the end of the day, what this COVID-19 has shown us is that 3 days of food stockpile and water supply is definitely not enough. And then what's enough? And I think that it's very hard to find the right balance between being adequately preparing and hurting and overstockpiling, in other words.
Yeah. Sorry, go ahead.
Go ahead.
I found it interesting, and I guess a little disappointing. Looking at the figure, how few people or how few households are prepared. If you kind of look at, just looking roughly, it's about half of households have about half the items, or have fulfilled about half the items, and you can kind of see, if there's 9 different categories, about roughly 50% have five of the preparedness items filled.
Yeah.
Yeah. So on a positive note, we're in the middle of a pandemic, so it's very hard to be optimistic. But one thing that I hope people can take away from this paper and this work is that life is going to go on. And hopefully this is really an opportunity for us to really double down on these preparedness messages, right? So COVID, I think, is this great illustration that the things that we might expect to happen didn't happen. So this is not the kind of emergency where a vehicle for evacuation is helpful. This is not the emergency where water stockpiles are needed, because that infrastructure hasn't broken down, though. But this really is a case where we need to have emergency food stockpiles. It's really important to be having financial security. It's important to have your plans and your documents in place. And so hopefully this is an opportunity for us in public health to really reinforce why all of these dimensions of preparedness are so important. COVID-19 has touched everybody, whereas a lot of these natural disasters don't necessarily hurt anyone except the most vulnerable. And so maybe this is finally a good wake-up call for all of us about why preparedness is so important for all of us.
I actually wanted to, sort of touching on that a little bit, one of the things that I really thought was very interesting in this study was the sort of highlighting some of the disparities between, both on socioeconomic grounds and also racial and ethnic grounds as well, just looking at sort of availability or sort of level of preparedness. And I think that's become pretty significant or highlighted a lot in our current situation. So I wonder if you guys could just talk a little bit about that in terms of the context of this study.
I think that there's a few things to highlight. I think that when we look at overall preparedness, the study finds that a higher socioeconomic status overall. So having more education, having a higher household income predicts a higher level of preparedness. And those things that appear to make somebody more vulnerable, like in the case of COVID-19, being older, at least in our study, shows that people who are 65 years and older are more likely to be prepared as well. So something that in the case of COVID-19 is an apparent vulnerability, in the case of our study, we find that those older people tend to be better prepared. Now, when you look at racial disparities or single households, we see that women who are head of the household tend to be less prepared than their counterparts. We see that in case of racial and ethnic minorities, so Black and Latino households tend to have inconsistent results in terms of preparedness. So for instance, in the case of some resource-based items, like having food stockpiles, we realize that some of these ethnic minorities households tend to be less prepared. But in terms of, for example, water stockpiles, these households tend to have a higher level of preparedness, which shows a little bit that preparedness is linked to some patterns of consumption in this household rather than that preparedness itself. So like Dr. Martin was saying, the importance of highlighting key, like improving our risk communication rather than improving preparedness overall might be part of like the take-home message here.
Great. I'm going to welcome Iyad Wahibi, who's joined us. Welcome. We're talking about disaster preparedness. Speaking of water stockpiles, one of the very minor trivial points I found that was really fascinating was you had exactly 10,000 households who had water stockpiles, which is it's always nice to have interesting round numbers out of a giant survey.
We checked that number a couple of times. Right as well.
Yep. All right. Well, I think that brings us to the end of the segment, but thank you so much. This is really an interesting paper. Obviously, it's unfortunately quite timely right now. But I think if nothing else, we've learned that, it's not like disaster movies. It's not suddenly the world shuts down. It's that suddenly things are different. Things don't just stop.
Yes.
Great. All right. Great. Well, thank you so much.
Great. Thank you.
Keep up the good work. Great. Well, we are going to move on to the next paper, which I'll scroll up here. The sensitivity of continuous electroencephalography to detect Ictal activity after cardiac arrest by Elmer and colleagues. So this is an interesting paper. I got to get into a little bit of background here because it ends up getting a little complicated. But basically, so most cardiac arrest patients are comatose after return to spontaneous circulation. And we find that a lot of them have some sort of Ictal, some sort of seizure-like activity on their EEGs. There's a giant spectrum, and they talk about a lot of the different details. If it's frank seizure, I think we all agree that needs to be treated with antiepileptics. If it's non-convulsive status epilepticus, there's general consensus that is treated. It's a little bit, it's clearly there seems to be some sort of prognostic data here. As far as if there are seizure-like activities on the EEGs, the patients do worse. The question is whether that is just the seizure activity is a sign of brain insult or if the seizure activity causes its own brain insults. There's, I think, what looks like low rates but increasing rates of EEG monitoring just kind of routinely after cardiac arrest. What they did in this study was they took data they already have, or basically from 2010 to 2018 at two hospitals at Pitt and UAB. They did a lot of EEG monitoring, and they look at all the patients who had greater than 24-hour continuous EEG monitoring. Basically, made a bunch of different definitions based on what's going on at background and whether they have epileptiform potential EEG patterns or epileptiform events. So basically like frank seizure-like brain activity. And then they kind of went back and then simulated doing kind of spot EEGs. Because the question is, if you're doing continuous EEG, it's labor intensive and it creates a lot of data that then needs to be analyzed. So would it be more, feasible or better or equivalent to do, just simple spot EEGs, like a standard 40-minute EEG, especially during just daylight hours? And would that be as sensitive and as good at predicting? There's a bunch of different analyses they did, but basically the kind of summary data they had 760 patients over the time period. About a third of these were shockable arrests. which we know in general do better because it's usually are more likely to be primary cardiac and more likely to get a good outcome for a bunch of different reasons. About a third survived. About a quarter of those who survived had good functional outcomes, which is, unfortunately in cardiac arrest data, it's bad. It's only 36 out of 760 had good outcomes, which is unfortunately pretty typical, but as one of my mentors said in residency, having died is a pretty bad prognostic indicator. Right. Not to make too light of it, of course. So they had 48,000 EEG hours, which is a lot, but averaged out about 63 hours per patient. 55% of the patients had at least one epileptiform activity at some point. They had about a third were in one of those epileptic risk-form states. About 40% had some sort of event. Only 3% had frankly treatable seizures. And they do a bunch of analyses looking at a bunch of different directions. But basically, if you're going to get 95% sensitivity of finding all the treatable things, you need over 50 hours worth of continuous monitoring, which is a lot. If you instead just do the spot EEGs, the sensitivity is only about 2/3, and it goes up to about 3/4 if you convert it. If you see something on that spot EEG, then convert it in the rest state to continuous for 24 hours. And there's also on average what they found about a 12-hour delay to finding something based on that kind of treatment algorithm. And then they also found some kind of prognostic things that basically, at baseline without doing EEGs, they could kind of predict about 7% of people who had basically no near zero recovery. And that increased to a sensitivity about 40% or a predictive value of about 40% with the continuous EEGs. So, there is some prognostic value here. You need to do a lot of monitoring to be really sensitive. But you get pretty decent sensitivity with just doing kind of non-labor intensive 40-minute spot EEGs. So that's a lot. That's a lot of numbers, and it's pretty complicated.
But I really, really liked this study because to me, this is now. So I guess the caveat should be that I don't know the literature on, post-cardiac arrest sort of epileptiform events, but it seems like this is one of those situations in which we do things, in the hospital that aren't necessarily, evidence-based, but we sort of do them at, thinking like, okay, well, more is better, like, particularly in the post-cardiac arrest situation. But I liked this study because this was actually showing, well, actually, maybe we can reconsider some of these things that we've been doing for a while. Which, the other thing that was so interesting to me was so the brief intermittent EEG had was very poor sensitivity for detecting treatable seizures. But I guess on the flip side, not that many people develop treatable seizures. Right. So there's sort of that trade-off. But yeah, really, really interesting stuff, I thought.
Yeah. The actual clear treatable seizures is tough because I think that's just such a small fraction, and it's, they're relatively short-lived. So doing just a kind of random 40-minute one is probably not going to catch that, I guess makes sense. But it's just kind of the general patterns of things like anoxic brain injury or potentially developing a seizure that has some value and adding prognostically. And also, from reading the paper, the intro and discussion here, reading the accompanying editorial, just the kind of broader context that, I'm not an expert in post-arrest management in the ICU like this. There seems to be the pendulum swing towards doing more and more continuous EEGs, and it's pretty labor intensive. There's a lot of costs in a lot of different ways. Yeah. So figuring out how to optimize that makes some sense, and just adding more data to practice that we're doing because it has face validity makes a lot of sense. Yeah. Great. All right. So let's move on to the next one. What do we have?
This is state policies on access to vaccination services for low-income adults. So this was a study that was trying to look at adult Medicaid beneficiaries' access to immunization services. And so it was looking at both sort of benefits coverage, but also reimbursement amounts for vaccines. And interestingly, I think they looked at the beneficiaries, but I think they also looked, if I recall, at some of the healthcare providers as well. This was really cool, very interesting. only 22, so about 43% of Medicaid programs actually covered all 13 ACIP recommended adult immunizations under both fee-for-service as well as managed care sort of organization arrangements. So I think this is about 37 of 49 fee-for-service arrangements actually reimbursed healthcare providers, but 8 out of 49 of those did not separately reimburse for vaccine administration to adult Medicaid beneficiaries, essentially. And the other thing that was very interesting about this was that they also looked at the median per dose reimbursement for adult vaccines by each vaccine. And the highest reimbursement is actually for 9-valent HPV, and the lowest is for Haemophilus influenza type B vaccine. So I don't know how all of that is determined per se, but I thought those were just sort of some interesting findings, kind of discouraging as well. Just, thinking about the fact that we do have certain vaccines that really are recommended for adults, and they're not all necessarily easily accessible from a financial perspective for people.
Yep. And it's tough. I mean, I think Medicaid is just so complicated. There's essentially, I think it's 56 different Medicaid programs that are jointly administered by the states and Fed and budgeted in a complicated way. And there's basically federal guidelines, and then states can implement in different ways. And then one of the things they looked at here was dividing between fee-for-service Medicaid and managed Medicaid. Yeah. And not surprisingly, the managed Medicaid plans were less likely to cover vaccines. And one of the other sad things too is that there was a fair amount of copays for patients or states that allowed copays, especially in managed care plans. Yeah. And the ACA's first dollar coverage guarantees for certain preventable services don't apply to Medicaid plans like this. Mm-hmm. And it's tough because in some ways it's hard, but it's also the scale of Medicaid programs. This stuff can get pretty expensive for states. Which becomes troublesome. The flip side is, it's you pay for things which give you value, and we're learning a lot about the value of preventative healthcare for infectious diseases now. So there's a lot here. I think Medicaid is just I don't know. I listened to a podcast a while ago with Harold Pollack from University of Chicago, who's one of the most brilliant people I've ever met, and put it really well. It's Medicaid has a ton of problems, but overall is really good, and there's just so much nuts and bolts stuff that could be improved. So data like this is really helpful. Going to welcome Naim Iqbal, who's joined us. Welcome. We're going to move on to our last paper, which is another change in gears. This is a research letter, The Association of Residency Training with Metabolic Measures by Matsuo and colleagues. And so this is a study from Japan where they looked at 281 Japanese medical residents in Tokyo and matched them to age, sex, and BMI matched controls who were not medical residents who went into the same primary care offices in Tokyo. And it's basically interesting. So first they looked at kind of the baseline thing. So there's some interesting differences in smoking and sleep patterns and alcohol. So not surprisingly, the medical residents were much likely to smoke, less than 1% versus 29%. Had lower amounts of insufficient sleep at baseline, only 25% versus 46% of the non-medical residents, which is interesting because we certainly think about medical residents as not people who sleep a lot. Although I guess it's pretty early in residency. Less alcohol use. So of those who answered more than rarely, it was only 25% versus 45% of the general population. And actually similar rates of exercise, 60 versus 53%. Then they looked at what happened over a year. So they basically looked at the difference between the two groups in changes over a year. These are pretty small changes, but these are relatively young people in a relatively short period of time. But there were still some, even in that relatively short time period, some pretty decent changes. So the residents gained an extra 0.25% of body fat, had some worsening changes in their cholesterol, both the LDL going up by 2 points and the HDL going down by an average of 3 points. And then interestingly, the diastolic blood pressure going down by about a point in the medical residents. So it's interesting stuff. Residency is a stressful time. You work a ton. It's not a lot of time for work, a lot of extracurricular work requirements, and a lot of stress, and not a lot of time and brain space for self-care.
Yeah, no, absolutely. I really love research like this because it just sort of confirms what I believe. Right. That residency is not healthy.
Right.
But it also just kind of made me think about, I thought about my own residency and like, those overnight calls where for me personally, I was going to the vending machine. Like you're just in general, you're not really taking care of yourself. Well, so I did, you already mentioned this, but I did think that some of these like secondary outcomes or aims that they were looking at were sort of interesting in terms of the smoking and daily alcohol use, things like that. Kind of demonstrating is a little bit of a, too much of a solid word, but I guess I'll say, illustrating that, these residents were otherwise kind of adopting healthy behaviors, but there's something about residency. It's tough.
Yeah. Although it's again, it's easy to, as usual, easy to kind of explain data without actually knowing for sure. But, residents, select people who are probably, more health literate, have more, more health knowledge in general. Also, it's really hard to do things like drink alcohol every day when you're in med school or when you're in residency. Plus all the socioeconomics that go into it too. The people who are, able to get into and go through medical school, there's a lot of benefits for people who come from more resource backgrounds. Right. So it's interesting stuff. And also there's also the giant nihilistic caveat here that these are really markers of, metabolic health. They're not health in general. They're kind of risk factors for health outcomes. It's not like these residents are all having heart attacks at a higher rate at a year. It's the intermediate markers here.
But we talk about that a lot, I think, just our disdain for biomarkers. But
right. Yeah. But that being said, these are again relatively young people having measurable changes in health measures in a year. So it's good. We've got a couple more people, Chef and Nimra Khan, who joined us. We are just finishing up right now, so you can get these articles and more at JAMANetworkopen.com. Every day they're free and open access. Every weekday we've got new papers coming out. And of course, join us next week on May 12th, 3 p.m. Central Time for our next episode of JAMA Network Open Live. So thanks for joining. Take care. Be safe.
Bye.